Hi everyone, welcome to your lecture on vital signs. These are the learning objectives that we will be covering in this lecture. We have explained the physiological processes involved in homeostatic regulation of temperature, pulse, respirations, and blood pressure. We're going to compare and contrast these vital signs, identify sites, assess temperature, pulse, respirations, and blood pressure accurately, identify normal ranges of these vital signs, and provide education to patients for each of these vital signs. What are vital signs? Vital signs are indicators of physiological functioning, and they reflect the health status of a person. These are crucial aspects of nursing. It's a part of our nursing process. We do this every day. These include temperature, pulse, respirations, blood pressure, pain, and pulse oximetry. So these are a few questions. Why do we do vital signs? Because they're an important component of care. They're part of our nursing assessment. Remember, we talked about gathering data about your patient. These are important also to identify changes in your patient's condition. They help to monitor and evaluate trends to prevent any complications. And they improve patient outcomes because we're monitoring and frequently checking for changes of status. When do we do vital signs? On admission. Based on facility policies, some facilities might want you to do it every hour, every 2 hours, every shift, every day. Make sure you know your facility's policies. Any change in condition. When you notice there's a change in your patient's condition, the first thing you assess is vital signs. Loss of consciousness. You want to get a set of vital signs. Before and after activity that may increase risks of, any invasive procedure or surgery. Increased risk. Because, for example, if the patient just came out of surgery, you want to do their vital signs to make sure, monitor for any changes of condition. Before administering medications that affect cardiovascular and respiratory status. For example, before you give a blood pressure medication, make sure you check their blood pressure first. Then every 4 hours or less in the hospital, daily, monthly in long-term care facilities, and daily at home. What are normal vital signs? These are the ranges, and this is from your textbook, chapter 26. And over here, we're going to focus on child and adult. Please go ahead and review this in the table in your book and memorize the child and adult. What factors affect vital signs? For example, when you go there into your patient's room and you're about to check vital signs, what are the different factors that can affect these vital signs, right? These are time of the day, morning, if you're taking it in the morning, during the day, at night, they can vary. Age and gender actually affects vital signs. Physical activity, if your patient just finished exercising, working with therapy, then, their vital signs will be different as opposed to if they were resting in bed. Their state of health, how sick are they? That also affects their vital signs. Environmental temperature, pain affects vital signs. Stress and emotions, medications. For example, if you gave a patient an antihypertensive and you go to check their blood pressure, it's going to be lower a little bit later, right? And so that's going to affect vital signs. And then food and liquid consumption. For example, if the patient just had a coffee or they had a cold drink, that's going to affect, their vital signs as well. So, sorry. Repeating this, let's go to the next slide. So now let's first talk about temperature. What is temperature? So your body temperature is the production of heat in your body minus the loss of heat. So remember, our body is always producing heat and always losing heat. So the difference between the two is actually your body temperature. How do we produce heat? Through metabolic activities. right? Eating, drinking, exercise, all these things. Sympathetic neurotransmitters, thyroid hormones, shivering, exertion, all of these things help us produce heat, right? We lose heat through the skin, through sweating. For example, our sympathetic nervous system, elimination of urine and feces actually helps us to, lose heat. And other physical processes like radiation is the diffusion and dissemination of heat by electromagnetic waves. For example, the body gives off waves of heat from uncovered surfaces. So that's why they say when babies are born, we cover their heads and stuff, because they lose heat from uncovered surfaces. Then we have convection. That's the dissemination of heat by motion between areas of unequal density. For example, a fan. An oscillating fan blows currents of cool air across the surface of a warm body. So the wind, the air blowing from the oscillating fan is, helping us lose heat. Then we have evaporation, the conversion of liquid to vapor. For example, body fluid in the form of perspiration, sweat, and insensible loss is vaporized from the skin. For example, when you're in the sun and you're sweating, that's evaporation. Conduction, the transfer of heat from another object during direct contact. So the body transfers heat to an ice pack, causing ice to melt. So this over here, for example, when you're using ice packs or heating pads, this is all, how we lose heat through conduction, for example, with an ice pack. That table was also from your textbook in chapter 26. Please go ahead and review it. The thermoregulatory center in the body is in your hypothalamus. The hypothalamus regulates the temperature at a fair range, the normal body temperature, right? And so that's what its job is. It regulates that temperature. If it gets too low, it tries to heat up the body. If the temperature gets too high, it tries to cool down the body, right? And so the heat production and heat loss, need to be balanced. So the neurologic and cardiovascular systems also work together to regulate the body temperature. So now when you're checking temperature on a patient, there are core body temperatures and there's surface body temperatures. For example, core body temperatures are your temporal artery. Then we have your tympanic membrane. That's also a core body temperature. Esophagus, your pulmonary artery, and your bladder. So this is where you get core body temperatures. And we have also, the rectum. That's also a core body temperature. Sometimes when you check the temperature, say, on in the axilla, in the armpits, and then you check it in the rectum, the temperature in the rectum is, higher because it's a core body temperature. Surface body temperatures include the skin, the mouth. So when you're doing an oral temperature, that's a surface body temperature. And the axillae, which is the armpits, that's also a surface body temperature. Factors that affect the body's temperature is circadian rhythm, right? It varies during the day, right? So it's 11 degrees, Fahrenheit, by about approximately 11 degrees Fahrenheit. Usually it's lower in the morning. So if you check a patient's temperature when they first wake up, it's going to be a little lower, right? Because your body needs to produce heat, right? Through metabolic activities. So they've been resting right now. So it's going to be low. Age and biologic sex. Old and young are very sensitive to environmental changes, and their temperatures can fluctuate. Hormonal changes can cause increased body temperature in women. For example, during the menstrual period or during menopause, the body temperature will be different. Physical activity and dehydration. For example, if you're exercising, your temperature is going to be higher. Or if you're dehydrated, it's going to be, that's also going to affect your temperature. The changes in health, the state of health, how sick you are, can also affect your temperature. Environmental temperature. For example, if the environment is extremely cold or hot, you can get hypothermia when your body temperature is abnormally low. So these are some keywords. They're in red, so please focus on these keywords as well. And then we have hyperthermia, where your body temperature is abnormally high. Recent food and fluid intake can interfere with accurate oral temperature measurements. For example, if you just had coffee and then you check your oral temperature, it's going to show a bit high. Then stress also affects the body's temperature. So let's talk about hyperthermia. This is when your body temperature is above normal. It's high. For example, when that happens, we have fever. The medical term for it is pyrexia. It's increase in above normal body temperature, greater than 99.9 degrees Fahrenheit or 37.5 degrees Celsius. Hyperthermia is high body temperature. Febrile is a person with a fever. Afebrile is a person without a fever. If you notice, all these terms are in red, so these are keywords in this lecture. Then we have fever is caused by upward displacement of the thermoregulatory center set point. For example, your hypothalamus. Remember, that's your thermoregulatory center. So fever is when it's just, it has an upward displacement. So, it's high. In response to, it could happen for different reasons, and we talked about what affects the temperature, right, in the previous slide. So it can happen in response to a pyrogen, some bacteria. And then the hypothalamus initiates a temperature-rising mechanism to destroy the pyrogen. When the temperature increases, then your hypothalamus triggers the heat loss mechanisms. So then what happens, it helps to prevent it from reaching dangerous levels. Then we have the causes. What are the causes for hyperthermia? Increased body temperature, exposure to pyrogens, tissue injury. How do we know that our body temperature is, increased? We have increased immune function and inflammation, which is a late sign of infection. Hyperpyrexia is a temperature greater than 106 degrees Fahrenheit, and that is definitely a medical emergency. It's not something we can cure with just Tylenol. It needs emergency medical services. Then you have neurogenic fever, which is damage to the hypothalamus from intracranial trauma, bleeding, or increased pressure. So if the hypothalamus is your thermoregulatory center of your body, imagine if that gets damaged, it's going to affect how your body regulates heat. And so your temperature will be off, right? Then we have a fever of unknown origin. There's no identified causes for it. It just lasts for 3 weeks or longer, and we don't know what the origin is. This is a list of the different types of fever. We have intermittent fever, remittent fever, sustained continuous fever. Then we have relapsing fever. Please read over these different types. So what are the signs? Physical signs of high temperature, of hyperthermia: loss of appetite, headache, hot and dry skin, flushed face, thirst, muscle aches, and fatigue. So these are the signs and symptoms of hyperthermia, increased body temperature. So when a patient has a fever, these are the signs you will see. So what do? We determine the underlying cause. That's the most important thing. We need to know, okay, why do they have a fever, right? If it's an infection, then we give them an antipyretic like a Tylenol and an anti-infective antibiotic to help get rid of that pyrogen, that bacteria that's causing the infection. Provide them with comfort. Prevent complications. Monitor that fever. You don't want it to go to 106 where it becomes a medical emergency. You want to monitor that fever. And doctors usually prescribe Tylenol. Just, administer whatever the doctor prescribes and antibiotics to help get that fever down. Modify external environment, right? If it's too cold or too hot, make sure the environment is comfortable for the patient. Increased oral fluids. Staying hydrated helps the body lose that heat. Then increase increase the intake of simple carbohydrates. Those help to reduce body heat. Then we have nursing actions, well, I'll show it to you in the notes a little later. Okay, so let's move on to hypothermia, right? We have decreased temperature. Hypothermia is decreased temperature where the core body temperature is less than 95 degrees Fahrenheit or 35 degrees Celsius. Severe hypothermia is less than 78.8 degrees Fahrenheit, and this can cause death. Remember, your body, to maintain homeostasis, it has to maintain all its vital signs, and including the temperature. So your body has to maintain, the hypothalamus thermoregulatory center has to maintain homeostasis. So this impaired physiological responses, altered perception of cold, these can all cause hypothermia. Then we have chronic conditions that can also cause hypothermia in some people. Pre-op patients and newborn infants have a high risk of hypothermia. Right? Therapeutic hypothermia is induced hypothermia, sometimes to treat medical emergencies or for surgery or something like that. Some patients are put into an induced hypothermic state. What are the physical effects of hypothermia? Poor coordination, right? Slurred speech. Imagine if it's really cold, or maybe you're in a place where it's snowing and it's really cold, your teeth start chattering, and then you can't really speak well, right? Poor judgment, amnesia, hallucinations, stupor. Then we have decreased respirations and decreased blood pressure, weak and irregular pulse. These are all physical effects of hypothermia. So how do we treat this? We warm the patient up. If the patient, we put warming blankets, heating pad, whatever it takes, we warm them up. Warm fluids via oral and IV route. Support vital functions. Support their vital functions. If their blood pressure is low, try to maintain that. Try to maintain all the other vital signs. Try to help their body stay in homeostasis. Prevent complications. Monitor, and this can be done by monitoring them frequently. Then what are the nursing actions? We provide a warm environmental temperature, heated humidified oxygen, warming blankets, and our warm oral and IV fluids. Keep the head covered, because remember, we talked about heat loss from uncovered surfaces, right? You want to keep the head covered. Provide continuous cardiac monitoring, because when your body is not in homeostasis, it can affect your vital organs. Have emergency resuscitation available and on standby. So these are the different ways we can assess temperature. The most common, obviously, are the non-contact infrared thermometers. Then we have the tympanic ones, the temporal artery ones. These are the electric digital thermometer that we use in the hospitals. Everywhere they have different types. Then we have disposable ones, and these are the automated monitoring devices, which are mainly used in the ICU. So assessing the client's temperature. How do we assess the client's temperature? Oral cavity. Right over here, the oral temperature. Ask the client to open the mouth, and most of the time with the client, you're able to check the oral temperature on the client. You can also ask the client to help. You can give it to them in their hand, let them hold it. It's more comfortable for them. And you ask them to keep their lips closed. They breathe through their nose until the thermometer is checked, it beeps, and then it's done. Now if they just recently had something hot to drink, then wait a few minutes before you go back and check it. Okay, then we have the rectal temperature, right? You lubricate the thermometer before inserting it in the rectum. Place the person on a sideline position, insert the thermometer 1 inch into the rectum. Be very careful. There are a lot of nerve endings there. You don't want the patient to, have a vasovagal response. Hold the thermometer in place for 2 minutes and remove the disposable cover and read the temperature and, throw away the disposable cover. Then we have the axilla. Take only when no other site can be used. A lot of times in healthcare, nurses and CNAs, they just go straight for the axilla, straight for the armpit. This should only be done when no other site can be used, right? Make sure the underarm is clean and dry. The arm is held close to the body. You need to hold the thermometer in place while the temperature is being taken. The thermometer is left in place for about 10 minutes or until it beeps. Then we have the tympanic one, which, we measures the temperature in the tympanic membrane in your eardrum. It's fast and accurate, 1 to 3 seconds. For infants, you pull the air straight back, and for adults and children over 1 year, you pull the air up and back. It's just because of the anatomy of the air on the inside. So for instance, infants pull back, for adults up and back. Then we have the temporal temperature, with just a light stroke across the head, a temporal artery of the forehead. An accurate reproducible temperature can be measured in about 3 seconds or until, obviously the thermometer beeps. So what are some contraindications? For oral, it's contraindicated in an unconscious patient. If the patient is unconscious, please don't go shove a thermometer in their mouth, right? Because that's not how we measure their temperature, because the patient has to be able to open their mouth, put it on their tongue, and close their lips. If the patient is unconscious, they cannot follow those directions. If there are any disorders of the mouth, recently had something hot to drink or they smoked, wait 30 minutes. It's extremely important to remember that. If they, if they had some coffee or they just smoked, wait 30 minutes. If they're receiving nasal oxygen via nasal cannula, do not use oral, their oral temperature, because then they're going to have to, like we said, when you're checking oral temperature, you tell the patient to breathe through their nose, but they're receiving nasal and they have a nasal cannula in their nose. So you're basically telling them, don't breathe till I check your temperature, right? Then you have rectal. It's contraindicated in newborns, small children. If the patient has diarrhea or had rectal surgery or has rectal disease, please do not check the rectal temperature. Okay, that is just not right. Okay, if you have a concern of a vagus nerve stimulation, like I said, there are a lot of nerves over there. If you're afraid that the patient might have a vasovagal response, do not use a rectal temperature. For example, patients who have cardiovascular disease, who have heart failure, normally with people like that, people with cardiovascular disease, we do not check rectal temperatures. Or any neurological disease. Axillary. The armpits, it's contraindicated with any disorders over there and after bathing, because obviously, their body is warm and the temperature will show high. Now, when do we use it? Oral is the most common. Rectal, when assessing the most accurate temperature, is the alternative to oral site. The axillary, the armpit, is when unable to use oral or rectal in newborns. Okay, assessing temperature. Here's a video. I'll put the video on Canvas for you to watch. And let's go back and let's talk about pulse. The pulse, the heart rate, or P for pulse, or heart rate. So we have different sites for pulses. We'll go over the sites in a minute, but the peripheral pulse is a throbbing sensation that can be palpated or felt, your fingers, over a peripheral artery, such as a radial artery or brachial artery. The most common site we use is the radial artery. The pulse rate is the number of contractions of the peripheral artery in 1 minute. So we palpate the site and we keep our fingers there and listen, feel it for a whole minute. Okay, the normal range for a pulse is 60 to 100 beats per minute. That's the normal. So these are the different sites. We have temporal, we have external maxillary, we have carotid. And one thing to remember when you're measuring if you're checking carotid pulse, please don't check both of them at the same time. You will kill the patient. Always do one at a time. Then we have the brachial, then the radial, and the ulnar, but the radial is the most common. Then we have the femoral arteries, then popliteal and dorsal pedialis and tibial. Characteristics of the pulse. Now, these characteristics are indicators of the effectiveness of how the heart is pumping and the volume of blood that it's ejecting, the cardiac output, with each heartbeat, and the adequacy of this peripheral blood flow. All of this is being measured by checking the pulse, right? So there are different remember, when you're assessing a patient, when you're recording assessments, you want to have measurable, you want to be able to quantify it, and you want to be able to measure it properly so you can document objective data. So what characteristics of the pulse do we check? We check the rate and rhythm. The rate is the number of times you feel that throbbing sensation. Should be between 60 to 100. The rhythm is the regularity of that pulse, right? For example, is it you hear the throbbing sensation like 1, 2, 3, 4, and then it disappears and then it comes back? No, that's irregular. You want a regular rhythm, regularity of beats and intervals between heartbeats. Dysrhythmia is irregular patterns of heartbeats. So if it's not a regular pulse, then there could be a dysrhythmia. Then you want to check the amplitude. Is how strong is that pulse, whether it's bounding, right? Strength and the volume of blood through the vessel, and it reflects the strength of the left ventricular contractions, right? So if you look at it, this is the way we grade. Remember, everything has to be quantified when you're measuring in measurements. So what is the grade? Absent is 0. You don't feel any throbbing sensation, 0. 1+ is diminished and weak. +2 is normal and brisk, and that's the normal. That's what we should expect, a normal, good pulse. +3 is bounding. When it's bounding, you'll feel it, like if you check your pulse, or if you check the pulse of somebody who has cardiovascular disease or dysrhythmias, you will feel all the differences in the pulse. Then the elasticity. Does it feel smooth and straight and resilient? This decreases with age, and with age it's less resilient and rigid. Equality. You want to check both the pulses in both radial pulses at the same time, both peripheral pulses, right? Whether you're doing the feet or the hands, wherever you're checking the pulse, you want to do them both at the same time, except for the carotid, right? So you want to make sure it's symmetrical when you check it. So once again, the rate, rhythm, amplitude, elasticity, and equality. That's what you want to measure. What affects the pulse? Age affects the pulse. Aging affects metabolic rate, and this can decrease the pulse rate. So older adults may have a decreased pulse rate, not increased, decreased pulse rate. Then we have medications. Many medications can cause the pulse rate to change. Some medications are actually made to help decrease the pulse rate for people who have have an increased heart rate. Biologic sex can also affect the pulse. Women on average have slightly higher pulse rates than men. Okay, physical activity. Physical activity can also increase, it increases metabolic demands, and because now you have increased metabolic demands, your heart is pumping faster to compensate, and this can cause your pulse and heart rate to increase. So your pulse rate will be increased when you're exercising. Now, well-conditioned athletes, for example, people who are, professional athletes and stuff, their pulse rates might actually be very, very low. It's because that's how well they have become conditioned, right? Because they're very efficient, and the strength of the heart muscle is strong from regular cardiovascular exercise. So their pulse rates might be low for athletes. Then we have body temperature. Increased body temperature. When you have a fever, it causes your pulse to increase. Why? Because your body has increased metabolic demands. And so to compensate, your heart beats faster. Then we have stress. Stress can increase your pulse rate. For example, when you're anxious, when you're afraid, or, when you're in pain, your heart is beating faster to compensate and circulate the body. And so this can increase your heart rate. Then health condition. Now, different health conditions can affect your pulse in different ways. COPD, chronic obstructive pulmonary disease, and pneumonia, and impaired oxygen, they alter the pulse rate. Sepsis alters the pulse rate. It increases due to infection. Peripheral vascular disease and heart failure also affect the circulatory system, and as a result, they will affect the pulse. So increased pulse is called tachycardia. Tachycardia is a rapid heart rate, which is greater than 100 beats per minute. If you notice, these are keywords again in red: tachycardia. Decreased cardiac filling time leads to decreased stroke volume, and cardiac output leads to decreased perfusion. Okay, and then persistent tachycardia indicates an underlying problem. So if the person always has a really high heart rate, that's going to increase their, that shows that there is some underlying problem. Normal response to exercise, right? Tachycardia is a normal response to exercise. If you go running up a mountain, then obviously your heart rate is going to go up. What are the contributing factors in nursing interventions? So what causes it? Decreased blood pressure due to blood loss, shock, or trauma. For example, people are in car accidents, or they're bleeding out, or they're in shock. They have, what happens is that if they lose blood, their heart is trying to compensate, and so their heart rate goes up. Their temperature goes up. If their temperature is high as well, that also increases their heart rate. Poor oxygenation of the blood. For example, in chronic pulmonary disease or anemia, people who have anemia or COPD usually have higher heart rates because their heart is trying to compensate, right? Exercise, hyperthyroidism, pain, strong emotions, fever, anxiety, anger, medications. For example, if you give somebody epinephrine or atropine, their heart rate is going to go up. That's what it's given for. It's for people who have real bradycardia, whose heart rate is really slow, or their heart is not stopping. They give them epinephrine or atropine to get it to beat again. So it will increase the heart rate. What are the nursing interventions we can do? What are the things that we can do as nurses? Monitor for pain, anxiety, restlessness, manifestations of low cardiac output. For example, fatigue, dizziness, hypotension, chest pain, low oxygen. Monitor for potential adverse effects of medication. Maybe it's a medication that they're getting is causing them to get tachycardia, right? Protect the client from injury. For example, if they have tachycardia and they're restless, they might fall, they might get injured. Protect them from injury. So these are the nursing interventions and the contributing factors for tachycardia. Now let's talk about bradycardia, which is decreased pulse. Slow pulse rate less than 60. So what happens is you have a decrease in heart rate, you have decreased cardiac output, that means the heart is not ejecting enough blood, and then you have a decrease in tissue perfusion. So if the heart is not ejecting enough blood, you're not getting enough circulation in your body and you're not getting, perfused. And we'll talk a lot more about this when we cover the cardiovascular system. So this requires treatment if the patient is symptomatic. Now, some people just have low heart rates, low pulses, for example, athletes, right? Now, if they're symptomatic, then it needs to be treated. It's normal in athletes, like we said. So what are the contributing factors? Coronary artery disease, myocardial infarction, that's a heart attack. Decreased body temperature can cause your pulse to go down. Hypoxemia or obstructive sleep apnea, not getting, enough oxygen in the blood. Acute altered mental status, for example, delirium, can cause, bradycardia. Hypothyroidism can cause bradycardia. Increased intracranial pressure and other central nervous system conditions. For example, a stroke can cause low pulse. Response to a vagal stimulation, example, ocular pressure, vomiting. For example, remember we said when you're checking the rectal temperature, be very careful to not give the patient a vasovagal response, because the vagal stimulation causes the person's heart rate to drop really low. Medications, for example, digitalis like digoxin or antiarrhythmics, they cause your heart rate to drop. Then we have, so what is it that we can do as nurses for our patients in this case? Monitor for manifestation of low cardiac output. See if they're having signs of low cardiac output. That's dizziness, hypotension, chest pain, syncope, which is fainting, diaphoresis, sweating, dyspnea, difficulty breathing, and altered mental state. These are all signs of low cardiac output. Monitor for potential adverse effects of medication. See if it's the medications causing, this heart rate to be really low. Protect the client from injury. Again, if their heart rate is low, when they're standing up, changing position, they might get dizzy and fall. So these are the complications from tachycardia and bradycardia. Checking the apical pulse. The apical pulse is obtained by listening with the stethoscope at the 5th intercostal space mid-clavicular line on the chest, which is right here. So this is mid-clavicle, right in the middle of the clavicle, and fifth intercostal space, right down here, is your apical pulse. So when you're checking the apical pulse, assess the apical pulse. First, you inform the client what you're going to do. If tolerated, lift the head of the bed and assist the client to a sitting position, if it's not contraindicated. Identify anatomical landmarks at the apex of the heart on the left side between 5th and 6th ribs. It falls right below the nipple or the breast, right? So you're counting between the 5th and 6th rib, right? Clean the different parts of the clean your stethoscope, place the stethoscope against the apical impulse. We call it the maximum impulse. We put that right there, and each lub-dub is 1 heartbeat. Remember, each lub-dub is 1 heartbeat. So counting the heartbeats for 1 minute. So each lub-dub is 1, lub-dub, 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 lub-dub. So that's 4, right? So you count each lub-dub as 1 heartbeat. Then you adjust the head of the bed, wipe the stethoscope, clean, and practice hand hygiene. So these are the steps to check the apical pulse. Remember, 5th intercostal space between the 5th and the 6th rib, mid-clavicular line. If you notice, it falls right under the nipple. What is the pulse deficit? It's the difference between the apical and the radial pulse. So if you check the apical pulse, you count how many beats there are, and then you check the radial pulse. The difference between the two is called a pulse deficit. Assessing apical pulses. This is a video. I will post this in your Canvas page for you to watch. Okay, so in the next lecture presentation, I will cover respirations and blood pressure, and then we'll talk about patient education.